So here we have a 52-year-old Caucasian female who's a never smoker with a history of clinical stage 2B adenocarcinoma. There are no actionable mutations identified by PCR. PD-L1 is 55%, and there was not enough tissue, unfortunately, available for next generation sequencing. So main question is, what is the next step in treatment? And so a little more information regarding the patient. Actually, this patient presented to the emergency department with abdominal pain. Of course, the patient got a CT scan in order to work up this persistent abdominal pain, and she has a great status. Her symptoms resolved with antispasmodic agents. Really notable medical history. She's got a history of allergic rhinitis and seasonal allergies. She, again, is a never smoker and has no family history of cancer. And so the CT of the chest and abdomen, or excuse me, the abdomen and pelvis didn't show any findings to explain her abdominal symptoms, but did show an incidental left lung lower lobe mass. So she then subsequently underwent a CT chest, which showed a 4.2 by 2 by 3.1 centimeter left lower lobe mass, and an adjacent left hilar lymph node. These were both hypermetabolic on PET CT, and her MRI brain was negative for metastases. So she underwent EBUS with biopsy and lymph node sampling. The mass showed invasive mucinous adenocarcinoma that was consistent with lung primary. It was also TTF positive. Station 4R and 7 lymph nodes also were negative for metastatic disease, but station 10 of the left side was positive. Again, her PD-L1 expression was 55%. All of the testing was by PCR, but there was not enough tissue, again, available to send for next generation sequencing. So my question to the panel is, what is your next step in your treatment? And we'll start there.
No surgery.
Correct. Not yet.
And considered operable.
Yes. Yes. So some of the follow-up questions I have, would you rebiopsy in order to obtain NGS, or would you, and would you decide to do that before or after resection? If she is liquid biopsy. Or do a liquid biopsy, yes. All open ended questions.
Sometimes people already salís quieren coger la media peso para ver unidades.
Yes. And why from what should do?
Well, my preference would be additional testing that babies would never smoker. I'm not sure. There is a counter argument about ECGN, and I think you're better served by, it's a never smoker, relatively young, I haven't been hasty. I think we're better served by knowing the complete molecular profile for this point. I think you could also make the counter argument that the person's ruled out with EGFR out, but thus within the preoperative chemo IO, you could just start that. This way hides into G-bias because broader tests and that's just not practice.
No, but that's an important point because you said that there is no tissue for NGS. We didn't say there is no tissue for PCR.
I said there's not enough tissue for NGS.
No, that's exactly what I'm saying.
But they ran
We don't need
PCR for.
We don't need NGS for this one. We need maybe PCR or maybe we don't need much.
Where they sent too much of it for IHC by accident and didn't save enough for NGS,
Correct.
which has happened.
But the PCR, we have results from.
Yeah.
Yes, they're all
Yeah,
negative.
you want to go back, Jenny? It is
Yeah.
all
We're
EGFR,
highly
PR.
important data.
No, no, it's
Yeah.
there, it's
Oh,
slide,
yeah.
yeah.
So really, the question is, yeah, I mean, if EGFR and ALK are negative, those are the two cancers for which we have effective adjuvant targeted therapies. You're not going to run the risk of overlapping TKI IO exposure if we started with chemo IO. PD-L1 expression is high, and by now the patient has already been going through the workup for 3 weeks from patent initial presentation or maybe longer. If you go for a biopsy now, we want to wait for another 3 or 4 weeks. It's going to delay surgery by a substantial extent. So chances are we're going to find that the patient has some mutation, but I would venture to go and say, start chemo.
Yeah, the worst case scenario would be, Dr. Rivera believed that there was no mutation for PCR. That would be the end of discussion that we would drop it.
You know, it brings up an interesting point, which I don't know how everybody feels about it, but do you treat never smoker with no mutations as somebody who has a mutation? In the refractable stage, in general, do they practice?
Yeah, like on a young patient with a never smoker biopsy many times, several ways, we don't find anything.
So do you treat, how do you treat that?
The best, I find a lot of energy one lady and RD2, so those patients are right in the middle, right? And they don't have actionable mutations, so like without actionable mutations, you don't have anything, right? And for this young patient, I am, is a diode never smokers, don't have a mutation. We then see biopsy somebody, because you're gonna get the same, if you get 2 biopsies, DNA and RNA, you get the same response, and the third biopsy is gonna give you the same. And there are patients that you don't find a cause, maybe because we don't know the mutation yet.
Exactly.
We didn't know,
It's just we
right?
didn't find it.
Yeah, we don't know yet, but we have emerging mutations like NRD1 and NRD2 and these other ones, but yeah, I treat them like they don't have mutation because they don't have a target mutation.
Yeah.
And we have,
So
Stage 4,
if,
that's it.
Yeah.
if you did find an NRG mutation, because you did further testing or rebiopsy or after the fact, or I guess after surgical intervention.
you don't have any trials for NRD1 to write the ABC for like it's a phase 1 trial, and we're defining times the drop like those level escalations are still very early. So you treat those patients with chemoimmunotherapy because that's also a requirement for the trial. You need to have progressive agents because those patients will try out. And the drug is not toxic, so it's not like it's a great solution either. Yeah. Yeah, we already have the phase 1.
Yes. And we other regular ways, but you can see it being wasted.
Yeah, you don't have to waste for regular chemo. So, I think in the summary from the panel.
Or yes, there is no actionable mutation, there is no actionable mutation.
I guess it's in what setting would you do adjuvant for upfront surgery rather than neoadjuvant?
So it's definitely for EGFR and ALK, not right. We knew that ahead of time.
And right.
Right?
And we had a trial here, right?
Okay, you have the trial,
Yeah.
okay, about it. Yeah, because I thought it would be something came on and this.
So let's release, yeah,
Okay.
No, but that's an interesting question. So you guys have seen chemo in everybody?
Not everybody. I mean, if you have a target mutation,
No, of course, but it's still no actionable. So you always had that warning for a chemo.
So,
Too late,
you know, there is, if you ask me, I would say we should do chemo for any resectable patient, as long as it's fortunate immunosuppressed, anyone who we would think systemic therapy does a role. Our surgeons probably would have a different answer. There are technical considerations. So this tumor is not going to be a straightforward one to dissect because it may end up being electrovenectomy with the hyaluronic node involvement, and we haven't seen the scan. So we definitely want to make sure we talk to the surgeons.
So at our center, if you're EGFRL or you're clinical stage 1, you generally go to surgery. Everyone else that get chemo IO, other surgeons have already adopted this. Yeah, very bad.
My group too.
Yeah.
My group's like, they're asking before we do the thing. And surgeons back, and we're scheduling patient now, all that stuff. So we're seeing it all in the same clinic, now just postponed.
Yeah. You,
And I guess how are you picking deciding between the neoadjuvant or perioperative regimens? And then
so the outcome.
There's managed approach.
sure.
Well, also depends on the response that you have initially. I don't think you'll have to make a decision although the patient goes to surgery, you have the surgical specimen and the table with the problem. I think we don't have a full consensus, but you might have hypothesis that the patient have a complete pathologic response. it's very hard to believe these patients saw a full year of pembrolizumab. It's still in guidelines, you still can do it. But I think you evaluate, with these new therapy, you evaluate as patients go. How well do you think with chemo? How was with the surgery? Did they recover right away? What is the response? And now every company has a perioperative trial. Now all of that approved prevention is, again,
The only caveat is that during and brief pathological response to the that's the review. That's why I respect if you don't want to do more, but this included the means to, I think the trial will go to the utility.
I mean, the way I think also about it is, it's in fact those who have it with the clinician who may not stop increasing each other one's school would actually be cured by not adding therapy because their response is just incredible. So it's either way, like.
yeah, I think it was discussion.
I did. If you look at what's the best predictor of cure, that's complete diagnostic response. Right, so that's important to bear in mind. To me, the role of post-operative IO is yet to be confirmed in this situation. If you just look at the two BMS trials, the two checkmate trials, one was just chemo for 3 cycles, followed by just surgery and standard of care. And then the lower trial, Nevo, there's not a big difference between the two trials, where they gave chemo, Nevo, and then had surgery and then went on. If you also look at the DFS hazard ratio, EFS hazard ratio, among the sandwich trials and just checkmate 816, they are very similar. So there is a need to understand. I'm not saying there's not a role for post-op IO. There's going to be a subset of patients for whom that's going to be helpful. You can look at the cup half full and full based on, if you make the case that if you already had a PCR, so that means the immunotherapy is worked really well, then do you really need more? That could be one argument you make. On the other side, if you don't have a PCR, your immunotherapy isn't working, why do you think more will bring it back? So you can make the case either way, and I think the cooperative groups are working on a card. Unfortunately, it's going to take a number of years before we can finish there.
But any of you guys are doing the MRD?
Not outside of the clinical trial.
Or is that any study for MRD after surgery?
So that's what the cooperative group effort is going to focus on. Personalized therapy based on both the PCR or non-PCR and then potentially MRD.
Without a trial, just collecting data, not making decisions, just collectively. And the question for you is, with that same argument of logic, mean that also the cycle is a different
I think before IO era, right, when we looked at trials that looked at chemotherapy, we didn't see a big advantage 4 versus 3 cycles. That's the same thing, even the veterans had 3 or 4 cycles for and it's providing the same. And in standard disease, 3 or 4 cycles doesn't make a difference. So I am very comfortable with 3 cycles in patients. And I enjoy looking about for eventual trials were done. I mean, do you have any?
Thank you for pointing out. I remember in my second year fellowship, I said to a thoracic surgical resident that adjuvant therapy has no place in lung cancer, and started saying that those trials will be revisited. And they were revisited. The biggest progress in lung cancer chemo was antiemetics. Because in the old days, as a negative, you couldn't give cisplatin with the old antiemetics. Zofran revolutionized lung cancer more than cisplatin did. So then those trials were redone in AVR, the new standard of care. So I actually say these things to them, but I'm not as sold on that.
So,
I don't have that numbers of the neotorch trial. The neotorch, they include only stage 3. They do 3 cycles not from, and then 1 cycle in the adjuvant followed by an IO. So
The problem with all these cycles, like Ricardo said, they all have differences, right? And it makes it very hard to compare because it's 3 versus 4, sandwich versus sandwich, 1B4, who they included tumor size. Some of them need the 7 edition, some of them are doing the 8 edition, the 9 edition is common. So we're gonna end project with the set of questions with different editions.
Only thing I would say is someone's really struggling don't tell them calendar 3 or 4 cycles. I do worry that we might get a chemo or IO toxicity and jeopardize surgeries, and some of the had a lot of toxicity after I've had 2 or 3. Okay.
And their patients have all responded either. I have a patient that we're all expecting to respond to the pathology came back, and I know here we are. You know, so you can do it. And most patients have the N2 distinct to be N2. By the time you go to surgery, you get the surgical specimen.
But are you also seeing, what you see is that sometimes on the CT of it, see such an impressive response, but then they resect the tumor.
And, I don't think we approve regimens for we fully understand the biology of the disease. So now the end with these patients that respond beautiful. A patient 3 cycles, full severe response. Other one 4 cycles, no mutation, nobody, no response. Very similar patients.
Any other comments?
So I'll just bring this up. I mean, again, there's no data about squamous versus adenoma. I personally have a bias for nevo in square versus nevo. Not for any particular reason except that data and more data always sees that nevo does very well in the square. Does anybody think of nevo versus what conventional histology?
I know scared of the squamous.
Do you mount any differentiation?
I see lots of
Yes.
So from both, and maybe for the only one, the second treatment, like they are looking in that, never the second treatment to me as some difference on the squamous cell carcinoma. So we're looking, as I mentioned, this very effects, but about the long term of the impact of the PNC, that core of the squamous cell carcinoma remains very supportive. So, in summary, I will tell you that what I do in my practice is I go perioperative. So I don't have to go this big, oh, your patient gets PCR, what I want to do. But I agree with Dr. Flores that if it's PCR, that have 1 year is too much. Well, at least we have 1 phase 2 randomized Nadine 2 trial that will go up to 6 months. So that's the one I use when I have a PCR. Because I agree with her that perhaps 1 year is too much, but we don't know. So we have that balance, that lack of data, Dr. Ramalia well pointed out and dissected. We need those trials to answer those questions.
And it's also hard, sorry, a surgeon comes and tells the patient, I took it all out, right?
Oh,
And then they come to the clinic, let's be honest, right?
Hey, nothing to do with that.
Oh, no, no.
What?
It works. No, it's not you, it's you.
Yeah, so then,
But who's in American college?
yeah, so then they come, right? And then you do the first CT scan, no disease. Okay. Second set of CT scans for 6 months. They're like, so there is no disease, do I need to continue on this therapy, right? He also the patient factor, where, well, it's not related to this, but we at Nora, we're facing that now. A lot of patients have been observed there for 2 years, that have 2 years to scan, no evidence of disease. And out of these patients, like, oh, it's okay, you know, so that's also another factor, because in thoracic, we're so used to seeing disease with drugs. But now it's more like breast cancer. No disease, you keep taking these drugs, so that's very important.
I just want to make a comment that what I tell such patients is, yes, we took out the closet full of termite, but you still need to tent and fumigate the house. Yeah, that may be interesting. And there's a steam. Yeah.
Also, it's a little bit painful, need to be very respectful, remain the survival rate, you know. But they say, oh, message 3, I'm totally sure, there are 5 years to not alive. That's because patient is basically without beautiful surgery to be dead in 5 years. So I'm like, unfortunately, we had to do that, and I have to explain that because I had the same problem. Surgeons always say, rescue, but then always coming to see you, and then you give the one year to his scheme.
Good point.
I have a question. So for the checkmate, like if you treat a patient with checkmate 816 regimen, like nivolumab and for 3 cycles, and then when you take them for surgery, if there is less than pathological complete response, would you be compelled to do more IO in the adjuvant setting? Or would you do more frequent scans? Like what is the approach like?
So you follow by regardless then, because checkmate 816 is the beginning of the DE2. Right? When you don't have a response, would you switch from checkmate 816 to the DE2?
Yeah, if you know, obviously it's unlikely because question. The question is no response or for response is the big question. Some response, maybe more immune.
So, and I use video, and when I had conmigo en un año más o the video, I remember that checked the kilo 671 has overdose survival already. I'm pretty sure that the other two that white people are data, they will be positive IgM as well as the checkmate 7017. Pretty sure that they will also reach overall survival down the line. Well, at this moment, we already have one that already proved overall survival in that perioperative regimen. So I just want them to hear that.
Another question is, when we have all of these drugs approved, would you use data with the PCR that's reported as something that we having on the inflammatory baptism after PCR was, or pathologic CR was 24, and Pembro was 19. And I've heard the data on tocilizumab, really single data, except at 50. So, but I'm favoring evil because of the PCR being higher and then go back to Arctic life.
Populations were different in the trials too. I think the high population of vivid smokers in T2N1 and of course the isonadenoline. And I think two patients all having SNLs piece of either that were typical stage. So that makes it like I think two patients were truly stage has the word compared to like always looking at the deaths.
Also, the name was stage 3, the only of stage 2, so that,
Yeah, we move by surface. So, and my opinion to your comment is, I think it's hard to say they will respond because so many patients are different. I think, as Jack Wesley said, oncologists are people of heaven. So I think people most like when you've been very semantic with this one that I've seen around. I'm being honest, that's what, we're in the minority here. Majority of patients are, out there.
people of habits. I know it.
It's true, they never been around, it's just been looking. But I used to.
Part of that is the more expensive Canada, the more premiums you're going to get.
That's weird about it.
And what the advantage that we have two of the leaders that were there, as well as people that was at a similar like Ram, Dr. Ravalina, and stage 1. Any effort on the stage 1A or 2B, because at the end of the day, when you see a stage 1A at 5 years, as you mentioned, it costs 30% of the patient at 5 years. Anything discussing that comparative look for 1A, now we have immunotherapy, on board at this stage.
There's a trial, a concept that's going to the press group, Steve Steering Committee, looking at the people under 4 centimeters, randomized them, so PD-L1 1% greater, randomized them to T0R rounds. I think there's other concept going through looking at that patient population, because the rate of relapse case head is clinically relevant.
Yeah.
And the next question is, will it be approved? Can be approved?
The most important thing is to find myocardial. That's an essence to therapy, any other therapy interview. So the challenge is to prepare to discover which risks are good, which risks are not. Because honestly, now there is a confidential data. It's very frustrating to do research like that, that you're giving growth and how the patient will in the this million. And then you're looking for a timing, it's very similar to and you could have. But not because you think that.
Then they can make a better with lung cancer screening, more smart aids.
Yes.
Yeah. A lot of my patients met.
Yeah.